Good morning. I'm calling to order this hearing. This is a hearing of the Committee on Health. I'm Councilmember Yvette Alexander. I represent Ward 7, and I also chair this committee. I am joined today by my colleague on the committee, Councilmember at Large David Grasso, and today is Friday, June the 28th. The time is approximately 11:25 a.m. and we are in the council chamber of the John A. Wilson building. The purpose of today's hearing is to discuss Bill 2153, the Omnibus Health Regulation Amendment Act of 2013. The purpose of Bill 2153 is to regulate several health professions that are currently unregulated and to strengthen the oversight of the practice of veterinary medicine by incorporating it as a health profession. It will permit the performance of general and sedation anesthesia by dentists and dental facilities. Further, the legislation adds dental hygiene, teaching licensure, and amends the Healthcare and Community Residence Facility, Hospice and Home Care Licensure Act of 1983 to require home care agencies to provide skilled nursing and therapeutic services in order to be consistent with the federal Medicare laws. This bill will also allow us to discuss the issue around licensing versus regulating personal trainers and distinctions from athletic trainers and physical therapists. We will begin with our public witnesses, and I will allow you as much time as you need because we have only 4 public witnesses today, so I will allow you to give your entire testimony this morning. I would like to recognize if Councilmember Grasso has an opening statement.
No, thank you. I don't have an opening statement. Thank you, though.
Thank you. Well, then I will call our first public witness panel, Michael Syndrome. Allison, is it Licky? I'm sorry, Miss Licky. American Physical Therapy Association, D.C. Chapter, Athletic Trainers and Personal Trainers. Dr. Stephen Gutenberg, the District of Columbia Dental Society. Come right ahead.
Thank you.
And Susan Walker, D.C. Coalition on Long-Term Care. Are there any other public witnesses which... Dr. Giannini?
Eugene Giannini, the DC Dental Society.
Welcome. You may begin with your testimony, Ms. Licky. Thank you. Good morning.
Good morning. Good morning, Chairman. There we go. Good morning, Chairwoman Alexander, members of the committee. My name is Dr. Allison Licky, and I'm the president of the District of Columbia Physical Therapy Association. The DC PTA is a professional organization representing almost 300 members who are physical therapist assistants, and students of the physical therapy in the district. The DC PTA is a chapter of the American Physical Therapy Association, which represents more than 80,000 members nationwide. Thank you for the opportunity to express our concerns regarding B20-153, the Omnibus Bill of Health Regulation Amendment Act. DCPTA has concerns regarding 2 aspects of B20-153, and we are currently opposed to legislation as introduced. However, we stand ready to work with the committee and intended parties to address these concerns and work toward a compromise on this important legislation. Our first concern is with the proposed language relating to the licensure of athletic trainers under the DC Board of Physical Therapy. We are not opposed to athletic trainers being regulated, as they are regulated in the vast majorities of states. And as colleagues, we value their work and contributions to the citizens of the district. However, we have some suggested amendments to provide further clarification on the scope of practice to ensure public safety. These amendments have been provided as part of my submitted testimony and communicated to the committee staff. The primary amendments we're advocating for the addition of the definition of the term athletic injury, as well as clarification the practice of athletic training does not include the practice of physical therapy or occupational therapy. and the DC Occupational Therapy Association strongly supports the proposed amendments. Our second concern is with the language in the bill that provides for the registration of personal fitness trainers. We have a number of questions and concerns regarding this aspect of the bill. First, personal trainers are not currently regulated in any U.S. jurisdiction, so we are cautious for the D.C. to be the first jurisdiction to do so until we have resolved some of the questions and issues that have been brought to our attention, and this is representing our members. The proposed definition for personal fitness trainers is very broad and could potentially encompass individuals who are not, in fact, personal trainers. We also have questions regarding enforcement, as it does not appear to be a mechanism of enforcement or repercussions for individuals who do not register. We are concerned about the potential for public confusion, as there is no language in the proposed regulations clarifying the registered personal fitness trainer shall not use the title RPT to signify their registration. RPT is a title specifically reserved to be used by physical therapists under Section 6710.5 of the D.C. Municipal Regulations for Physical Therapy. Finally, we have questions about the impact of licensed physical therapists who also serve in the capacity of personal trainers. Given the uncertainty and the questions as to the necessity and the capacity to regulate personal trainers, as well as the potential impact, we respectfully recommend that the language related to personal fitness trainers be deleted from the bill at this time to allow further discussion and study. We stand ready to work with the committee and with the intended parties to work towards a compromise on this important legislation. Again, thank you for this opportunity to provide our input to the legislation, and thank you for the members of the committee for your work on behalf of the citizens of the district. I'd be happy to answer any questions.
Thank you. I'm going to allow the entire panel to complete their testimony, and then I'll ask questions. Good morning.
Good morning, Chairperson Alexander, Mr. Caruso, council members, and any support staff. My name is Stephen Guttenberg. I'm a dentist. I'm a board-certified oral and maxillofacial surgeon and a physician who has been practicing dentistry and my specialty in the District of Columbia since 1971. I'm currently the chairperson of the Anesthesia Committee of the District of Columbia Society of Oral and Maxillofacial Surgeons, and I was the chair of the Anesthesia Task Force for the District of Columbia Board of Dentistry. In addition, I'm past president of the American College of Oral and Maxillofacial Surgeons, and I'm also currently the chairman, as I have been for the past 25 years or so, of the Training and Education Committee for Oral and Maxillofacial Surgery residents at the Washington Hospital Center. I'm here today to speak about that section of Bill 20-153, the Omnibus Health Regulation Amendment Act of 2013, that addresses the Board of Dentistry's role in regulating the administration of all types of anesthesia provided by dentists and dental hygienists. The District of Columbia Dental Society wholeheartedly supports the efforts of the Council and the Committee on Health for focusing on the issues addressed in this bill. However, we feel that the bill would be stronger and the health of our citizens better protected if the exceptions listed on page 8, line 14, through page 9, line 11, were eliminated, letting the Board of Dentistry tackle these issues as outlined in the recommendations from the Anesthesia Task Force that have been distributed to you. Those suggestions were the compilations of hundreds of man-hours of research and discussions by Task Force medical and dental members, and were produced after reviewing and evaluating numerous national and regional anesthesia regulations and best anesthesia practices. As you know in that document that has been supplied to you, the emphasis has been placed on a patient's state of consciousness, rather on the specific drugs that have been administered. Any specific drug, whether it be nitrous oxide or prescription or over-the-counter pills, can have markedly different effects on the recipient. Concentrating on a patient's level of awareness is more critical. This attention on the patient's consciousness state provides a greater level of safety for patients and for control by the Board of Dentistry. I'd also like to share with you the fact that the District of Columbia Society of Oral and Maxillofacial Surgeons, in the absence of any municipal regulations, has been self-policing itself for many years. No less frequently than once every 5 years, every office and oral and maxillofacial surgeon that sedates patients is evaluated to make certain that their entire office, the doctor and staff members, as well as the facility itself, the drugs, the equipment, whatever, are up to date and working, and that any patient emergency could be appropriately handled. Mock emergency scenarios are also presented to see how each office would handle patients under medical stress. This could serve as a model for the evaluation of all dental offices sedating patients in the District of Columbia. This information is also outlined in the Anesthesia Task Force recommendations for the Board of Dentistry. In closing, I'd like to thank the committee for the privilege of being able to address these issues and let the board know that I'm available to answer any questions and be of any service. Thank you.
Thank you for your testimony. Good morning.
Good morning. It's nice to see you all again. Councilmember Alexander, Chairperson of the Committee on Health, Mr. Grasso, staff, thank you for having this opportunity in this hearing on the Omnibus Health Regulation Amendment Act of 2013 and giving me the opportunity to testify. My name is Susan Walker. I am a retired medical home care geriatric social worker and a senior volunteer advocate for the DC Coalition on Long-Term Care. The DC Coalition on Long-Term Care's goal is to expand and improve the quality of long-term care programs, ensuring that Washington, D.C. residents with chronic care needs age in the community safely and with dignity. The greatest strength of the Coalition is the active participation of its volunteer members whose deep expertise and experience allows them to identify problems within the long-term care systems in the city and develop timely solutions. Both government agencies and community organizations work with the Coalition on a wide range of problems. In addition, the Coalition is able to bring together city agencies that deal with separate pieces of long-term care to communicate and collaborate on solutions. As a result, the Coalition's consumers, advocates, and healthcare providers have assisted in the development and implementation of expanded Medicaid home care, the improvement of assisted living residents and home care agencies, as well as the expansion and improvement of the workforce essential to these programs. There are two concerns that the D.C. Coalition has with the Omnibus Health Regulation Amendment Act of 2013. One, the Home Care Improvement Act of 2012 would require home care agencies to provide skilled nursing services and at least one other therapeutic service to an individual. This statute's purpose, according to Natwar Gandhi, is to make the definition of home care agency consistent with Medicare's definition of certified provider and to require a home care agency to provide the services directly and not through a contractor. However, because D.C. has only one definition of a home care agency, it forces all agencies to be skilled care providers. The reality is that some home care agencies provide supportive or custodial service to individuals who require assistance to remain in their homes. The Coalition believes that these supportive services are needed to provide the bulk of the care to the 67,695 D.C. residents living with a disability, including 24,937 residents over the age of 65. Forcing these agencies to become skilled home care agencies places an undue burden on them to provide services that are not needed by their private pay or grant-funded clients. This is why the D.C. Coalition has urged that there be two levels of home care agencies, one for intermittent acute episodes of care funded by Medicare and Medicaid, and one for long-term supportive custodial services funded privately by patients and families or through specially funded programs. The D.C. Coalition has argued for division of services since June 2010, when we requested regulatory revisions to the Health Care and Community Residence Facility Hospice and Home Care Licensure Act of 1983, and I have attached a copy of that report in your packet. The D.C. Coalition has always been concerned with the intent of the home care licensure law to make all home care agencies follow a medical model. The trend nationally is for a home and community-based model. The D.C. Coalition hopes that when D.C. unveils its home care regulations that they will follow the national trend. As I am sure the Council is aware, when legislation is introduced or amended, unintended consequences must be considered. I would hate for quality agencies to be negatively impacted by this legislation, especially if it did not fix the intended problem. The D.C. Coalition would like to see the Department of Health and home health agencies come together to discuss the problems that the D.C. Department of Health and D.C. Healthcare Finance are experiencing and try as a community to solve these problems. When there is one bad apple in the barrel, all the apples are affected, and the D.C. Coalition would be happy to offer their facilities to begin this dialogue. Our second concern is that the proposed regulation and licensing of assisted living administrators, home health care administrators, and nursing home administrators, on the whole, we approve with these three groups of people should be regulated and licensed. However, many people who have successfully run small assisted living and nursing home facilities might be negatively impacted, although they run excellent facilities. We urge that the regulations take these practitioners' length of service and experience into consideration and grandfather them under this statute. The Committee on Health has a unique opportunity at this point in time to make a significant impact on the well-being of D.C. residents. The D.C. Coalition looks forward to working with the Committee on Health to see that opportunity become a reality for the residents of the District of Columbia. Thank you again for allowing me to participate today.
Thank you for your testimony, and good morning.
Good morning. Good morning, Councilmember Alexander, Mr. Grosso. My name is Eugene Giannini, and I'm a resident and a dentist here in the district. I'm here representing the members of the District of Columbia Dental Society who are committed to improving the oral health of the citizens of our city. I've served as the president of the DC Dental Society, and I've been honored to serve as a member of the DC Board of Dentistry's Anesthesia Task Force. The result of this task force was a recommendation paper for anesthesia guidelines to assist the DC Board of Dentistry in the development of updating licensing and certification efforts for the profession of dentistry. I've submitted a copy of this report to the members of the committee. The members of the DC Dental Society welcome and support the work of the DC Board of Dentistry in regulating the practice of dentistry and safeguarding the public. I'm here to speak against the portion of the Omnibus Health Regulation Amendment Act of 2013 that proposes to amend Section 201 by inserting language into the current code that deals with the establishment, membership, terms, and responsibility of the Board of Dentistry. The proposed amendment, while reasserting the function of the Board of Dentistry to, quote, regulate the practices of dentistry and dental hygiene and dental assistance, proposes to give the Board of Dentistry the authority, which they already have under current legislation, to, quote, adopt regulations governing the administration of general anesthesia by a dentist and the administration of sedation by a licensed dentist. The proposed regulation goes further and exempts certain facilities and dentists from certification regulation based upon types of medications or agents used. It does not address the safety concerns outlined by the Anesthesia Task Force, nor does it take into account the training or safeguards of those dentists or facilities offering these services. It is counterproductive to give the Board of Dentistry complete authority to regulate the practice of dentistry, including anesthesia and sedation, while at the same time allowing certain entities to be exempt from that authority. It is our opinion that this amendment attempts to regulate the practice of dentistry outside the jurisdiction of the Board of Dentistry by making an administrative change to those regulations that dictate the Board's existence and composition. The DC Dental Society supports and recognizes the Board of Dentistry as the sole body that should regulate the profession of dentistry and safeguard the public. The changes to anesthesia and sedation practices as outlined in this amendment pose the potential to put patients at risk. The proposed lack of oversight by the Board of Dentistry over the use of medications to alleviate anxiety without proper clinical training or certification is dangerous and is not in the best interest of the public. We are in favor of regulations that ensure the safety of public as addressed in the report of the Anesthesia Task Force. We are in favor of these regulations coming from the Board of Dentistry and being amendments to the DC Municipal Regulations, Chapter 42, as they relate to dentistry and not as suggested in this proposed legislation. We're asking the committee to remove the proposed legislation, all restrictions upon the Board of Dentistry to adopt regulations on the practice of dentistry as proposed in this bill. We've submitted a draft of an amended version for your use. On the second aspect of the proposed act that addresses dentistry, basically the establishment of teaching licenses for dentistry and dental hygiene, the DC Dental Society supports this measure and feels that it should be adopted. Thank you for your consideration.
Thank you. Now, the question seems to be, and one as far as the Board of Dentistry is concerned, with the anesthesia practice. Now, I know medical doctors are not allowed to do that. Is that correct? Medical doctors, well, there is a anesthesiologist that does that particular function.
Ordinarily, that's correct. Dentistry is different. Certain branches of dentistry, particularly oral and maxillofacial surgery, have been leaders in ambulatory anesthesia that have kind of set guidelines for other aspects of medicine and dentistry as well. So, for example, oral surgeons, as part of our training, we get about a year or so of general anesthesia training in the hospital and in the operating room, and therefore routinely provide sedation and general anesthesia as part of our practices in the real world.
And the regulation now proposes that there be separate licensure of the anesthesia portion.
Well, as we put out in the board report, it points out that we feel that there are other people that are providing anesthesia services to dental patients. We feel that should be more closely regulated for the safety of patients. So we want regulation. We just feel that the way that this current omnibus bill is presented, it exempts a certain number of people who are providing those services from oversight by the Board of Dentistry. We don't think that's safe.
Who would be exempt? What are some of those groups? And please forgive me, we are 10-minute rounds of questions, Councilmember Grasso. Thank you. Who would be exempt from that?
Okay, I will tell you.
I didn't realize there were other.
No, it's exempting facilities where a dentist administers or has general anesthesia or sedation administered, or patients, and also exempts people who administer nitrous. It's not it's the exemption of the procedure or of the type of medication. Of someone who prescribes an oral medication to eliminate anxiety, or another method of eliminating pain with the administration of nitrous oxide. So the bill is insane. The bill is basically calling out, no one's saying that the board has to do this. The board has the authority currently and has current regulations in effect regarding these procedures and these types of procedures. What this new legislation is calling out, it's saying that the board may adopt regulations governing the administration of general anesthesia and sedation, except these limitations within that. We think that the Board of Dentistry should look at the whole spectrum of types of everything from relieving anxiety to general anesthesia, and look at that as a whole, and then come up with, if they want to advise the regulations, they're free to, as they are currently, but we don't know why this current legislation is being put forward to do that.
Have you spoken to the board?
Yes.
And what has been some of the conversation?
I think there's perhaps a mix-up on language. I think the board wants to have the control over dentists who are performing any level of sedation. The point is, the way that this regulation is written here, it says, for example, nitrous oxide and taking a pill. Well, you can give one person nitrous oxide and give them a pill, and they may be talking to you like you and I are speaking. On the other hand, you may give another person that, and they could become unconscious. Taking that level, I would not feel safe if a dentist was doing that for that patient, because if they don't have the training, if they went to a weekend course to learn how to give nitrous oxide and a pill to sedate somebody and then be exempt from any oversight by the District of Columbia Board of Dentistry, I think that's incredibly dangerous for patients as well as for the board not to have that oversight. In the task force that I chaired, the anesthesia task force, we very specifically speak about levels of consciousness as being the key. If you're going to do something that's going to make someone a little giddy and be able to still talk to you and perform all their functions, and their respirations or breathing and their heart is fine, that's okay. We're not saying we want to go into your office and regulate you. But if you're giving those same patient medications that are going to make them unconscious or semi-conscious, well, yes, we feel that you need to have certain equipment there to resuscitate patients. You need to have the knowledge and the ability to perhaps intubate a patient, put a tube down their throat to provide an airway, which they may lose with these medications. It's all about safety, Councilman.
So you feel this regulation, in fact, opens the door for more people to be able to induce the anesthesia?
Exactly, in an unsafe manner. Not saying they would, but this allows them to, whereas by taking that language out of there and letting the Board of Dentistry follow the guidelines which the task force did, will be much safer for the district residents.
Or even keeping to their current guidelines. The current guidelines have certain safety regulations in them. For if you're going to take nitrous oxide, it actually has educational requirements within them.
So who made this recommendation?
We just saw it. It came to us as part of the act. We realized this on last week when it was brought to our attention. There was a hearing on it today. We have no idea.
So there was, in fact, an anesthesia task force, and they did not recommend this.
That is correct. I was the chairman of that, and I have the document here, and you should have that document. That was not as part of there.
We believe there is an effort on the behalf of the Board of Dentistry, and we welcome that additional oversight. However, if it's going to be oversight, we want it over all levels of anxiety control and sedation. We don't think you should carve out certain levels of it.
Exactly. Well, I will inquire with the board where that came from. Thank you. Personal trainers, fitness training. Are you physical therapist?
Physical therapist, yes.
And do you also do personal training and fitness training?
I teach wellness also as a part of my realm. So we are trained in what you could, as the definition is here, yes, we are trained in personal fitness or as it is defined here. So we do act in that, and it's a part of, the overall wellness realm that we do treat.
Now, when I think of a fitness trainer or personal trainer, I think of someone who is almost, and I guess there are different levels, and that's where the confusion comes from. It could be anywhere from an aerobics instructor to a actual person who has nutrition background, physical therapy background, personal training, athletic trainer background. Do you think it needs to be in the health profession for fitness trainers to be licensed, or should it be outside of the health realm?
So currently, personal trainers are not nationally recognized by any standards of care, any sort of certification. It ranges from a 100 questionnaire that you can look up all the answers online to actually schools of thought where you can go and you can get specific certifications. So there's extreme variability within the realm of personal training. And I think that's where our biggest concern is that athletic training has very specific certification, education. Physical therapy has extreme, guidelines for education and our licensure. So we have a very defined scope of practice and standards of care. And right now there is nothing of personal fitness training of standards of care nationally.
So what should we do in terms of letting the residents know? It's a thing of awareness. When I figure someone has a license, then I'm going to feel confident in that person having the expertise in that field. So what can we do? There are a lot of fitness trainers out there, athletic trainers, personal trainers. What can we do to ensure that fitness trainers really know what they're doing out there?
Well, I think this is what Dr. Sonora Simpson and I have been discussing, because this is a concern, a public safety concern, but amongst personal fitness trainers there is no consensus. And so even trying to license them, there are no sort of guidelines within the training session or any sort of education. So a registration, but again, this definition within here is very vague and it is very generalizable to other professions. So it's not specific, and really there is no definition of personal fitness training.
So we would, in essence, have to develop a whole curriculum around it before we could license them, or what would you recommend before we license fitness trainers? Or you say don't license them?
So that is our biggest concern, is that we have talked to many other states and various areas that have been working on this, and they do not have a consensus. So that is where we don't know where to start, and that's where we're kind of looking at, we need to possibly study this more, because how do we develop a scope of practice or standards of care or ensure public safety, because there is so much variability. So that is our biggest concern, that we do not at this time have a consensus on where we should be going with this.
So just for the fitness trainer?
Just for the fitness trainers.
Okay, thank you. I'll inquire about that as well. And you mentioned two concerns you have that relate to the long-term care. The first one that you say a skilled nursing service, so it has to be direct services. So you can't train. This is saying that you cannot, it has to be directly from that skilled nursing service and you can't contract.
Right, that's what the Department of Health is wanting to do, because there are there's been some problems with some of the agencies who have been doing sort of contracting or pass-through billing, and the quality of care has been an issue. So this is an effort to try to curb those problems. But as whenever you do something which you try to sometimes solve one problem, you cast a wide net and you involve a whole lot of other people. And what my concern is that a lot of home care agencies who provide custodial care, which is like personal care services, because we only have one level of home care agency definition in the District of Columbia, they would have to also have skilled care services, which is expensive. It has lots of regulations and requirements, and it's very costly, and it defeats the purpose of what custodial care really tries to provide and make it affordable. You know, whenever you add regulations to any business, you increase the cost, and that's the concern also. It doesn't necessarily improve the quality.
So there would be no distinction from a skilled nurse and a home health care aide, if this is the case?
Yeah, so a custodial care agency would then have to add some skilled nurse services to their organization, even though they're basically providing custodial home health aide services. And so it changes the whole structure of their organization. And we have been urging since 2010 for the home care licensure law to have two levels of care. One would be intermittent skilled nursing, Medicare certified, Medicaid certified agencies that provide all levels of skilled care, which is nursing, physical therapy, occupational therapy, plus the personal care aid services. But those are very limited, versus the custodial, which we are calling home support services. And every other jurisdiction in this area has either what they call residential services or home support services. The District of Columbia is the only jurisdiction that does not have this.
So that would be a non-clinical
Yes.
position?
Non-skilled, yeah.
Non-skilled. Well, I think it's some skill to it. I don't
I
like
do.
non-skilled.
I agree with you entirely, but unfortunately, that's not the way they define it, so.
So there should be a skilled and a non-skilled
Yes.
licensure.
Absolutely.
But I don't like that term non-skilled.
We call it home support services because that's really what it attempts to do, is to support patients in their homes and provide them with the care they need to age in place in dignity and safety. It's absolutely critical to have it if you're going to have care in the home. And having been in home care for over 30 years, I can tell you many times a family would call and they would hear the skilled care agency was leaving and say, I don't mind if the nurse leaves, but please don't take my home health aide.
Exactly.
Because they're that critical to the whole process. But what we're doing now is making everyone a skilled care facility, and it's just, it means that we can't really provide the custodial services that we really need.
So that would, in essence, put the home health care, all the home health care agencies out of business.
Well, I don't know if it would put them out of business. I think they would try to figure a way around it, but I think it would increase cost. I think that they would, have a lot more difficulty in providing the services. And so we really feel that it's important to have this distinction. At first, it looked like the District of Columbia was going to allow to have skilled care services and staff nursing agencies, and then there was problems that arose out of that. And so now the nurse staffing agencies are only agencies that provide staff to other agencies. So now we have a bunch of people in the District of Columbia who are providing custodial services who are in limbo as to what they need to do regarding their licensure. And that's why it really needs to be settled.
Thank you. And I know I'm over my time, Councilmember Grasso, if you could bear with me. You had one more concern with the administrators.
Right.
You said assisted living, home health, and nursing home administrators, and you're saying it may be a conflict for them?
Well, what's happened is that in the District of Columbia, there are many people who have taken homes, sometimes their own homes, and they are providing services to 3 or 4 people in their home. So they're not like the big assisted livings or the big nursing homes or anything like that, but they're really providing this small group experience. And they have, many of them are nurses who have been in the business for years, before the nursing practically was a profession. They're very experienced, they're very caring, and they provide exceptional services. And as someone said to me today, that's probably where I would like to go versus a big agency. But they're not going to have the kinds of qualifications that you're all going to require for those kinds of licensure experiences. And I do not want to see them be forced out of the business because they can't pass that exam right now. I would like to see them grandfathered in so that they continue to provide the excellent services they have been providing. And over time, then everyone will have the requirements that you're looking for. But these people have experience that is just exceptional.
Thank you.
Thank you.
Councilmember Grasso, if you have
Thank
any
you
questions.
very much. Good morning, everyone. Thank you for coming down. It seems there's a bit of a theme going on here in all 3 of these areas, and I'm not sure really if this is the legislative action is the appropriate way to go about doing these things, and that means that sometimes we get stuff sent to us in law that probably could be better figured out if it's done in the Board of Dentistry or somewhere else, or really just thought through in a different way. And Ms. Walker, in particular in your case, I'm disturbed by the fact that it sounds from your testimony that there wasn't a whole lot of discussion and collaboration on this before it was sent to us, and I just wonder if you could reflect on that a little bit. What you're saying makes a lot of sense to me. I'm not an expert in these things, but it sounds like if you were a little bit in touch with reality, you probably wouldn't have gone to this extreme in hopes to maintain some of the services that are available.
Well, I understand where the Department of Health is coming from. They want to protect the community, and they really have some difficulty. Unfortunately, wherever there is money, there are people who are going to try to get a part of that pot. And sometimes they don't do it in an appropriate manner. So they are trying to protect. But, this is a discussion that we've had with the Department of Health over time, and there are people, I think, in the Department of Health tend to feel that the medical model is a better model. For those of us who have been in the community and worked in the profession, we're not so sure that that's really the way to go. We've had discussions with the Department of Health, and we would like to have a whole lot more. And and we are like today. The reason Judy Levy, the coordinator, is not here today is because she's having a meeting with the DC Health Care Finance regarding the patient-directed care that we've been working on.
Great.
We think that working collaboratively and with the providers is a better way for all of us to go to meet the needs of the patients of the District of Columbia. But I understand that they have their role to play, the Department of Health has its role to play, and I certainly don't want to get in the way of that, but I do want to bring to people's attention the unintended consequences.
Right. I think that's important. I think that's good that you came down today, and I appreciate that. Ms. Likey, I think you're in a similar situation. Although I can see what's trying to go on here. Like, I think it makes a little sense to me that folks be licensed and we know who they are, and when you advertise, you should have some relevance there. However, I also agree that putting a label on something or giving a license, like you mentioned in your RPT signification, out there from the government that's not clearly defined and hasn't been really thought through to the fullest extent might cause problems. And that gives me pause here. The other thing that gives me pause in your testimony, which I'll be looking forward to hearing more about from the government, is this has not been done anywhere else in the country, and that always makes me a little bit nervous. I don't know if you can reflect on that. You talked about it from the perspective of no one can get to consensus. Well, we don't always work on consensus, but is there some best practices, or is there associations that have actually built up or are working towards a model that we can adopt here in the future that will give us some direction here around licensing of, whether they're athletic trainers or physical fitness trainers, or however we want to define them?
So in relationship to the fitness trainers, recently nearby Maryland, they were actually discussing going forward with a registration or certification for fitness trainers. When this was discussed, over the last few years after this had actually started, there are a lot more places popping up on these online certifications for fitness trainers. So we thought they were kind of going towards a consensus, and it looks like they're going away from a consensus of what actually constitutes a fitness trainer. And so that is where I know Maryland pulled the bill because there needed more study to move forward with any sort of. They did not move forward. And that is kind of the concerns that we're facing right now, too, is that do we need to study this more? Do we need to look at it? Because what is actually protecting the public and what is actually truly required by a personal fitness trainer? Because what is their realm and scope of practice? Is there anything specific and is there public safety issues? So what is the concern? What are we trying to protect? What is their knowledge base? And what kind of consensus can we come that they should have a required knowledge base of? Because what is their job?
Excellent. Well, again, I think that's worthy of further discussion, so I appreciate you bringing that to our attention. And then I have to admit, I have a father who's a dentist and a brother who's a dentist, and so I can't ever understand really where dentists are coming from. Sorry about that. But anyway, I'm just kidding. It sounds like the Board of Dentistry is the appropriate place for them to do this regulation. So I'm curious why you guys think this came forward in legislation rather than continuing to do this in the regulatory process.
I don't think that we can respond to that. I think it would be a better question for Dr. Howard, the chairman of the board. We just feel that in this case, we want more regulation as opposed to most people saying they want less. I think that when it comes to safety associated with the anesthesia being provided by dental providers, that regulation will serve the public better.
I think that's true, and I think also the task force's recommendations, I think are well thought out, and we should give them a lot of weight here. And so I'll be looking to hear what the board's comments are on this, and certainly support you in saying that there should be more regulation in this arena. So
I hate saying that, but that's what our position is.
Well, I think my brother and father would agree with you on that as well.
Thank you.
The reputation is important, and regulation gives you a better reputation. So thank you for for coming down and for your service as well, both of you in the District of Columbia, and trying to make our industry a really good example for the rest of the country. So thank you.
Councilmember.
Thank you all for your testimony. And now we will call on our executive witness, and I guess I would recommend that all of the witnesses stay tuned for the executive testimony. I'm going to ask some of the questions that you all have concerns about. Dr. Waldo, the Senior Deputy Director of the Department of Health, the Health Regulation Licensing Administration. And Dr. Waldo, you're going to give your testimony first, and I will break out the questions pertaining to each board, so I'm sure that each member will join you.
They will be testifying on behalf of the boards as well, so maybe they can join me, the separate boards.
Okay, well, I'll have you because I don't have room on the panel for everyone. But I can call a couple up, sure. Dr. Simpson, would you like to come up? Dr. Sonora Simpson, Chairwoman of the Board of Physical Therapy. Karen Skinner, Interim Executive Director, the Board of Nursing. Dr. Daniel Howard, III, the Chairman of the Board of Dentistry. Good afternoon. So, Dr. Waldo, are you going to proceed? Good morning. Good afternoon.
Good afternoon, Chairperson Alexander and members of the Committee on Health. I am Dr. Star Waldo, Senior Deputy Director for the Department of Health and Health Regulation Licensing Administration. I'm here today to present testimony on the Omnibus Health Regulation Amendment Act of 2013, a compilation of legislative measures designed to increase protection for the consumers receiving health care services in the District of Columbia. The Act proposes the following: amend the Health Occupation Revision Act of 1985, which is the HORA, effective March 25th of 1986, DC Official Code 3-1203.02. This would include renaming the Board of Nursing Home Administration to the Board of Long-Term Care Administration and requiring licensure for the practice of assisted living administrators as well as the home health care administrators. It also requires registration for the practice of athletic training and personal fitness training, as well as practice of audiology assistants, speech language pathology assistants, and speech language pathology clinical fellows. It also creates a teaching license for dentistry and dental hygiene. Also, to require certification for dentists and dental facilities to permit the administration of general sedation, anesthesia by dentists. It also creates the transfer of the Board of Veterinary Medicine to replace the Board of Veterinary Examiners, requiring certification for the practice by veterinary technicians and veterinary euthanasia technicians and regular veterinary facilities. This Act also amends the Healthcare and Community Resident Facility, Hospice, and Home Care License, Home Act of 1983, to require home care agencies to provide skilled nursing and therapeutic services, therefore revising the definition of home care agency to be consistent with the federal Medicare laws. The current definition at DC Code of 24-501 states that home care agencies is licensed to provide any one of the following services: a program of health care, habitative and rehabilitative therapy, personal care services, home maker services, chore services, or other supportive services to sick individuals or individuals with disabilities. The proposed bill will require that a home care agency provide at least one skilled nursing services and one therapeutic services. This requirement will decrease some of the complexity associated with this licensed category. Consumers will have no question about the source of the care they receive or the parameters within which license can operate. In regulating the home care license category, the Department of Health has found that activities of licensees who provide only non-medical services, typically patients who receive only personal care aid services, numbered in the handlers per provider. Though the inspection process, HRA has identified that providers are not constantly ensuring nursing oversight and the tracking of transient patients and staff. It has also been demanding to maintain the legally required distinction between a home care agency responsibilities and those of a staffing agency. Also note that some licenses that offer only personal care aid services typically object to having to comply with standards applicable to providers of skilled services. The Department intends to address these issues and other by revising the existing regulations on home care agencies. The first step in this process is revising the definition of home care agency to adjust these parameters within which we believe home care agencies can more effectively function. Secondly, under the proposed definition, licensees would have to provide directly and not through contractors skilled nursing services and therapeutic services, which might include personal care services. The Department's interest is in promoting home care agencies as healthcare agencies whose primary directives follow prescribed order by medical professionals. In addition, HRA wants to require that licensees that operate at home care agencies be staffed and qualified to provide key services. Finally, in addition to eliminating the personal care aid-only home care services, the amendment would delete from the licensure requirement businesses that provide only homemaker and chore services. The Department believes that this amendment will allow the implementation of needed change in the current regulation of home care agencies. This amendment will accommodate our aging population and the growing need for the provision of professional health care services at home. Thank you, Chairperson Alexander, for giving me this opportunity to testify, and I will be happy to answer any questions you might have.
Thank you. I'm going to reserve until all of the panel gives their testimony. But on a personal note, Dr. Simpson, my mom says hello. You may proceed with your testimony.
Good afternoon, Councilman Alexander, the staff, and the other members of the committee. I'm Sonori Simpson, Chair of the D.C. Board of Physical Therapy and a practicing PP for 56 years. Thank you for the opportunity to testify on behalf of Bill 2153, particularly the sections requiring the licensure of the practice of athletic training and the certification of personal fitness trainers. Two important and very prevalent healthcare providers who are not regulated in any way in the District of Columbia. This is not a turf war. The sole purpose is to ensure that all of the citizens of the District of Columbia, the rich, the poor, the educated, and not so well educated, be able to understand professional titles, education, practice, regulation, enforcement, and discipline processes of our growing professions. We recognize that many consumers do not really understand the depth and scope of the practice of physical therapy and know less about athletic trainers and personal fitness trainers. It is extremely disconcerting when all of the titles sound alike, the identifying initials are nearly the same, and the advertisement seems to promise the same things. We also accept the fact that all professions have some overlapping functions and that no one owns certain procedures and interventions. It is most important for the public to know the basic level of knowledge and training one should expect for whichever profession, and they should be able to readily access someone with authority when there are adverse outcomes from any of us. Even used car dealers can be reported to someone when the clunker fails. The amendment to license the athletic trainer is required because we failed to follow our leading jurisdictions and much of the nation who already license them. The attention to the growing use of the personal fitness trainer and the unbelievable lack of any jurisdiction over the practice is a nationwide failure. We all have heard anecdotal reports of injuries, sexual misconduct, and misrepresentation of the titles by persons claiming to be competent in that area. It's a lucrative business. However, there are many very competent individuals who provide an invaluable service to the proper population. The public should have a level of confidence that when they select those practitioners, as the former council chair once said, this is the good housekeeping seal of approval for a group of important providers. The boards must sensitively monitor, guide, and educate our licensees while ensuring consumer protection and informed choice in a myriad of settings. Today, we thank you for your leadership to move the amendments of the Health Occupation Provision Act. I can assure you that all of the amendments in this proposed legislation were carefully drafted, reviewed, and revised to ensure that they meet all legal requirements. We could not have done it without the extremely dedicated and professional administrative and legal staff in HIPLA and the Department of Health. Nearly 5 years ago, the Board of Physical Therapy began our process by conferring with our professional organization, the American Physical Therapy Association, the Federation of State Boards of Physical Therapy, the American College of Sports Medicine, and the National Council on Strength and Fitness. For clarity regarding the personal fitness trainers, we met with local representatives from the major gyms here and the fitness centers and the YW and YMCA. We do recognize that there may need to be some tweaks to the language in these bills. The very nature of healthcare delivery has changed so rapidly since the original concept and the time it takes for proposals to wind through the system. The supporting regulations will provide much of the sought-after details of the practices. At that time, the public will be able to provide invaluable feedback and suggestions to ensure that these will be model regulations. However, all of the amendments in Bill 2153 need to be addressed or passed so that the public is well informed and can make sound choices regarding their health care. For the first time, many will be selecting insurance coverage and trying to choose the most appropriate level of practitioner to address their needs. In addition, for us, the Council passed a very much needed bill which mandates proper assessment and treatment of athletes, especially with concussions and sports injury. The Affordable Care Act expects and rewards preventive measures and measurable outcomes. You've heard from the president of the D.C. chapter of the APTA. This demonstrates a fine working relationship that our board has with our professional organization. While Ms. Leakey and my roles are different, we collaborate extensively and effectively while fulfilling our individual mandates. She ensures that the APTA's members' interests are protected, and I'm determined that all of the citizens of the District of Columbia, many of our professionals are not members of the APTA, and we want to make sure that our citizens are protected and well informed about the roles and responsibilities of the PTs, the PTAs, the personal fitness trainers, and the athletic trainers. Thank you again for this opportunity, and I'll be happy to answer any questions you might have.
Thank you. Thank you for your testimony. Good morning.
Good morning.
And good afternoon.
Afternoon. Good afternoon, Chairperson Alexander and Councilmember Grosso and staff. I'm Karen Skinner, Interim Executive Director for the Board of Nursing Home Administration. I'm still the Executive Director for the Board of Nursing. Steve Nash was unable to be here today, and he asked that I read the testimony on his behalf. I'm pleased to appear before you today to testify in support of the Omnibus Health Regulation Amendment Act. The Nursing Home Administration Board was established to regulate the practice of nursing home administrators. This proposed legislation will replace the Nursing Home Administration Board with a Long-Term Care Administration Board. The new board will allow us to expand the authority to regulate home care and assisted living administrators. It will also expand the board from a 5-member to a 7-member board. Healthcare delivery is changing. The patients who 30 years ago would have been hospitalized are now receiving care in nursing homes. Patients who would have been placed in nursing homes are now in assisted living facilities or at home receiving care from home care agencies. Our population is aging. To protect our citizens, especially our senior citizens, we need to ensure that the persons charged with managing these facilities are appropriately educated, competent, and ethical. As we do with all licensees, we will be able to validate their qualifications and require criminal background check. Requiring licensure will increase the professionalism of our long-term care administrators by setting licensure requirements such as levels of education and certification. Most importantly, the board would be able to hold long-term care administrators accountable for the services that they will provide to our citizens. Unsafe, unethical practices can be reported to the board for possible discipline of the administrator. We see this regulatory change as forward-thinking. As our healthcare delivery system changes to accommodate healthcare reform and our aging population, we're starting now to put in additional safeguards in place to ensure quality patient care. We look forward to our plans to expand the work of the board. Thank you for your attention, and I'm pleased to answer any questions you may have.
Thank you for your testimony. Good afternoon.
Good afternoon. Good morning, Chairperson Alexander and members of the Committee on Health. I am Daniel Howard, dentist and chair of the Board of Dentistry, and I'm here on behalf of the board. The pending legislation contains provisions to address two distinct areas. First, of course, is the one related to sedation and general anesthesia performed in dental offices in the District of Columbia. Due to the tremendous demand from the public for dental services performed under sedation and general anesthesia, it is of the highest importance for the district to ensure that the dental practitioners and facilities administering sedation meet the standards that promote health and safety. The certification standard proposed in the legislation is one that has been established in other jurisdictions of our country and has been deemed best practices. The second priority proposed in the legislation is to create teaching licenses for dental and dental hygiene education. We are fortunate in the District of Columbia to have the dental school at Howard University. The university requires qualified faculty to continue training prospective dentists and dental hygienists. The pool of available teachers is national and international in scope. So by providing a teaching license, the proposed legislation will deepen the pool of faculty candidates and enable the dental school to draw upon a wide selection of qualified practitioners to enrich and enhance the quality of dental education in the District of Columbia. On behalf of the board, thank you for your attention and your support, and I would be happy to answer questions.
Thank you all for your testimony. I'll begin with athletic trainers, personal trainers, and physical therapists. Now, and am I hearing something different in your testimony than I was in the public testimony for physical trainers?
I think one of the things is that we certainly wanted to make sure, and we've talked about the name of what they will be called, what the personal trainers will be called. The first concern that I had from the chapter, not from the chapter, but from nationally, was, of course, originally they were called personal trainers, PT. PT is a protected term under our law. In addition, we knew that many of these people would say they were PTs, which was confusing to the public, because then most people, and I'm old enough to know that some older people, if you say I'm a PT, they then think it must be the PT that I saw when I was in the hospital, that you're the same. To let you know why this becomes a problem in the district for me and for the board and I think for the public in general is that remember that we have very affluent folk, and we especially have the Hill, where the proliferation of these personal fitness training kinds of people is really big. It's big money and it's big. And so therefore there is a market here that's greater probably than any place that you can think of. So that we wanted to make sure that PT was protected, but we also wanted to make sure that people knew what they were getting and what could be expected and what they were paying for. I was astounded when I awakened one morning to find someone who was selling his wares of how good a trainer, personal trainer he was, with this morbidly obese woman. And I thought, oh my God, she could have a stroke right there with what he was doing, because he was using the techniques that you learned many, many years ago about, no pain, no gain. That's not practice. And so I said, well, what would happen if this woman dropped dead? And I went to, Dr. Waldo was not there at the time, but I said, who has jurisdiction over these people? All the attorneys and everybody said, nobody. So I said, what if something happens to her? Nothing, because they don't even have a business license. You right now could become a personal fitness trainer simply by saying, I'm a personal fitness trainer. And if I were unwitting and wasn't educated enough to know to ask, where did you get what you know how to do? You wouldn't get an answer. So anybody can proclaim themselves to be one of these things.
Well, now, Dr. Simpson, you mentioned that it's needed in this jurisdiction more than any other jurisdiction. Now, there haven't been any other jurisdictions that have found the need to regulate.
Many of my colleagues in many states, and as you know, I have been involved with a lot of this, with the Federation, which we look at all the states. Many of them have not simply said, because, as Allison said, well, we don't know what training they have, and we don't know, we don't have anything to base it on, and some of them are quite politically astute, and so a lot of those companies will say, we don't want you to touch it. So that's why I met early on, 5 years ago, with the big gyms. And those people, Gold's Gym and all of the other big gyms, said that would really help us, because we agree we have not come to consensus about what education it is, but it would help us because then we could set up some standards, and then all of our people, we would pay for them to get it, and that way we would be we would have a certification. There is an organization that has some baseline kinds of things. So in regulations, we could say it can't be online. It can't, what things it would be. That organization that I mentioned, that national...
And yeah, because when, and Councilmember Grosso brought it up too, what guidelines are we using? There's no education requirement.
Yes, they are, in this, to get a certification by this organization, they do have a basic amount. It said what we were aiming for was that they would at least have a high school education. But there, if you go, we could work with the committee and also to show that there is one agency that in...
Yeah, because how are you demonstrating that you have knowledge in the area of physical training?
And they have a test, and they also have some basic standards to be certified by that agent, that company, I'll call it. And so that's the National Council on Strength and Fitness, the NCSF. We met with them. The closest any jurisdiction has come to accepting what might be the minimal standards are the standards set by the National Council on Strength and Fitness. That's the closest to what, when we keep talking about consensus, that's the closest that we have. So the analogy would be the people that certify the med techs. That is a company that sets out some standards for them, and then if you can be certified by that company. We could adopt those as saying that's the minimum requirement in order to be certified as a, and if you notice, we are using the term fitness trainer because we wanted to get away from PT.
So
they are personal fitness trainers. They would be PFTs, but they would not be able to say or in any way confuse anybody saying they're PT.
So would coaching or strength training or performance training, would they be included?
Yes, they would be in that if you look in the whole business of why certify rather than license. Licensing usually indicates that you have standards of practice already set, you have codes of ethics and all of that. That's why you go to licensing. Certification and registration is usually done in a different way. So if we wanted to say that these are DC certified personal fitness trainers, we could adopt that they have met these measures, whatever measures that we decide. Again, when regulations are written, and most of the time we have to worry about people understanding that things that are put in statute are different than those that have regulations clarify all of the good things that we've heard. That's the same thing that we heard in dentistry, is that the regulations tell you the specifics. Who it is going to, who's going to be, whether they'll be grandfathered in, how they will get their certification, who would be required to be certified. We know that physical therapists are also certified because they're certified by the American College of Sports Medicine as personal trainers. It's a separate certification. They are physical therapists, and they also may be athletic trainers, but the public has to know when they are performing the duties under which title. So you don't bill for acting as a athletic trainer. You do not bill under codes for physical therapy. There are different standards, and we often have physical therapists who supervise athletic trainers, and in this state, they would have to be called aides.
How will personal trainers know that they can't use that designation of PT?
Again, it's similar to what we did with the PT assistants, is that we would pass the rule, to have the regulations, have a time for them to come in to be certified, and then enroll them, and then they would have the listing or wherever. I don't care where they are. They could even be on the business side. That it is certainly possible that this group of people would be certified like hairdressers.
It's just going to be, well, and I can imagine it's going to be a challenge because these fitness trainers, I mean, aside from the ones that are in the gyms and the locations, a lot of them freelance and work with individuals, and a lot accept, cash only.
Exactly.
Payments. So it's going to be really a challenge to actually license.
No, we're not licensing them. We're certifying them.
Straight.
Well, it'll be a challenge to certify.
Yeah, it will.
And ideally, are we going to look to license them? Because ideally, wouldn't we need to have a standard for every trainer, just like in every other profession, that these are certain standards that you at least have to have?
And the standards would be set as to who would be certified.
Okay, so they would be certified.
There would be standards to set that.
And Councilmember Grosso, I guess it's going to be a 10-minute round for each board.
Yeah.
But I just had a few more questions. Would the registration fee for the personal fitness trainers include the process and the fingerprinting cost?
Yes. As a matter of fact, it was interesting when we met with the Gold Gym, they wanted to know about how much it would cost, and they would set aside the fund, this was 5 years ago, to pay for all of their trainers. They were that interested.
So how will this be enforced? How would it be enforced and by whom for the certification?
Again, the decision about whether it would come under health or whether it would go under the other side of what's his name? The business side, DCRA, could be determined by the council. I'm not really saying that it has to be under us. We brought the bill forward. But
if it's just a certification that you're talking about and not a license, I don't...
Well, Councilman Alexander, I think that it would be fabulous if you want to propose that we go a step further. I can assure you that this would we would have to do a lot of talking with our colleagues about this. Because, again, when you license, then there's the next thing that people would be afraid that they would be able to bill Medicare and Medicaid, et cetera. So, again, talking about unintended consequences, you could open up a whole can of worms.
And it's really going to be a concern because now they're saying that obesity is actually a medical condition now.
Exactly.
So I don't know if this needs to stay in the health arena, not because soon I can see fitness trainers being able to bill. If obesity is a medical condition now,
I wouldn't have dared to say that 5 years ago, but it just shows you what 5 years will bring. You are absolutely correct. I would certainly do everything that I could to help bring it to fore, but the original intent was to have something that you and the public would be able to say, you're a trainer, you must have high school education, you must have taken these courses, et cetera. At least it wouldn't be in the jail, and that, or if it were in the jail, that would be some education that had been sanctioned by someone.
And so my last question, what would the penalties be if there are penalties established if someone were marketing or training and they actually did not have their certification.
This is the guru about that.
So what would be the penalty for that? If someone was advertising in the newspaper or?
Yeah.
Just like any other profession, first I'd like to clarify what the difference is between licensure, registration, as well as certification. Registration specifically just talks about that these professionals or these providers of care in the District of Columbia are known to the Department of Health. And there will be some basic requirements, either a certification to be registered. But once you are registered, there will be some basic requirements. As much the requirements will be, they will have to be, they have to graduate from some specifically required by the board, as well as they would have to go through criminal background check. So we know that they are crime-free. Also, they would have to have ethics courses, so they know about boundary issues or any other issue. And then the public will have an opportunity, if they have issues with that practitioner, they have a place where they can report it to, so that person is not going from one place to another doing what they do. So registration is a step down from licensure. For us, registration will just let us know that they are known to us, and if there is any ethical, professional, or competency issues, that we can take action against their license or against their registration.
Thank you. Councilmember Grosso, I'm going to just reserve the questions for the Physical Therapy Board until I move on to the home health care.
Okay. You want me to go now? Yes. All right. Thank you. I just want one more question on this. How much does it cost to get certified under this plan?
Well, at the time that we did it, of course, now remember I said it was $50. I'm sure it probably, it might be, again, this is a guru on pricing. I don't do pricing, and that was not the point. The point is exactly what he said. But they would determine what it would cost. It's not to make money. It would be to cover the costs.
Okay. Most of them are required to be certified, really, to work in the business settings where.
In the gyms and stuff.
In the gyms and stuff, yeah, they would have to be.
Okay, thank you. Dr. Howard, I wonder if you might answer a few of the questions that were raised earlier. There was a task force, as you know, brought together on these issues. They put forward recommendations. In your testimony, you say that what's put forward is the best practice around anesthesiology. And so how is there a conflict there? I mean, it seems like possibly for the first time ever, certainly in my short career here, we have an industry that wants to be regulated more, but your recommendation is to accept some of these things. So can you explain that and what's going on there?
Yeah, I think so. There was a tremendous effort to develop legislation around this anesthesia and sedation, general anesthesia and sedation. Tremendous effort to the point where I, as a part of the board, established a task force, which the two gentlemen that spoke earlier were part of the task force. The task force was made up of different parts of the community, or of people who would be either affected by or who could participate in presenting information about to develop this task force. It included everybody. Now, in addition, the next step was to look at jurisdictions around the country, especially like Virginia and Maryland, in terms of these jurisdictions already have regulations, permit regulations for this process. And so we in the district did not have. So in other words, there was a tremendously broad effort to do this. And I think in writing the legislation, there was just, I don't say it was left out, but there was a change maybe incorporating everything that everybody recommended. And so this is how it turned out.
Would you support the recommendation?
Absolutely, absolutely, I would. But what we'd have to do, though, is go back to the board and get a consensus from the board in order to bring this forward. But absolutely, this is an excellent recommendation.
Well, I think that's good to hear, and certainly hope you can go back to the board. But we could also just take your recommendation and their recommendation and move forward with it here in the committee as well, if the chairwoman's up for it, and make that change if that's appropriate. Perhaps what we can do, Chairwoman, is if members of the board reach out and say that they don't want this to happen, then we'll consider that as well. But otherwise, I'd suggest we move forward to fix this problem and make sure that there's adequate regulation around this. So I really appreciate your service as well, Dr. Howard.
Good, thank you.
I know you're probably busy in your practice, and to do these kinds of things on a daily basis or on a weekly basis is a bit of a burden. My brother does serve on the Virginia Board of Dentistry as well, and so he reminds me daily that it's unpaid service to the state, and I appreciate that.
So how did you not become a dentist?
Oh, you're kidding me. That's all the questions I have for this panel. I think that it's always a balance, as you know, Chairwoman. The balance is around regulation and oversight and the government intrusion into businesses and how we do it in a way that promotes safety and security and awareness for the public. And I think it's hard to always get it exactly right. So I appreciate you having a hearing on this, and certainly we'll work with the committee to get each of these areas done right and done in a way that best serves the people of the District of Columbia. So thank you very much.
Thank you, Councilmember Grosso. To continue along those lines, then, I wanted to, well, now we've come to some consensus that you've heard the earlier testimony, so we're going to work that out.
Good.
With regards to the anesthesia process. So that's been collaboration. I don't think I have a lot of other questions for you. That was a major concern, so I look forward to working that out in the legislation. I don't want to show favoritism, but the dentists are a very collaborative group. So thank you for that. For the home health care, I wanted to ask, it's been reported that the department is already having difficulty inspecting, different places now. I know we're spreading ourselves thin with inspectors, and now we have maybe even more facilities that we'll have to inspect now with the home health care providers. Do we have enough inspectors for the entire city? I mean, and I'm talking everything from food trucks to the restaurants to, places of business now we have, and now the home health providers. So that's going to be an awesome task.
The home health agencies are licensed and regulated by us, and we are supported by appropriate money as well as federal money. So we get federal money to do our health inspection.
So we have the money. Do we have the people?
Yes, we do have the people to inspect.
So
we are not proposing to open up the home care agencies. We are just proposing to strengthen our ability to enforce our laws and redefine some of the...
So would it be based on complaints then for those inspectors to go out?
We do licensure surveys as well as certification surveys. And we do also respond for complaints.
So specifically, how many inspectors do we have for home health care providers?
Currently, we do have... So we have 2 for licensed home health agencies, and then another 2 for certification. For certification.
For all of the home health?
23 of them, yes. And 25 of them are
So are they dedicated to this, or would they do other inspections
No, they're
as well?
dedicated to that. We do have dedicated staff for those.
I'm sorry, you said 33 or 45?
Home care agencies.
33. And 2 are dedicated to that?
Two for licensure and 2 for certification. Those are for certification to participate in Medicaid and Medicare.
Now, I understand that the rates are much higher for those providers in Maryland and Virginia. So will this licensure drive the businesses out of the District of Columbia? Or what is your take on that?
I don't believe so. I mean, this does not change the way they are licensed.
It's not changing how they are licensed?
No. We just changed the definition, how we first of all, we are trying to make sure that home health agencies provide the services that they are responsible for.
Did you hear the argument about the skilled versus non-skilled? So how are we going to meet that challenge where a lot of home health care providers just give the custodial or the personal care? So how are we going to make that distinction with that now? Now we're raising the bar for those persons that Maryland and Virginia are not doing.
No, the issue is, at the health department, what we are trying to regulate is healthcare services that are provided in those settings, especially in the settings, in home settings.
That are non-clinical.
No, clinical. We're at the health department. So as the health department, what we try to regulate is under the SHPTA, which is the State Health Planning and Development Agency, that requires all home care agencies must have a certificate of need. And the certificate of need is to establish that there is a need for those services. And those services are defined by the healthcare services that they provide. So we want to make sure that all of the home care agencies at least provide one therapeutic or healthcare services to a patient or to a disabled person.
So what's going to happen to the home health care agencies who do not provide any clinical services?
So that is where I think we have heard the argument of creating a two-tier system where there are, and I don't know who should regulate those, that are just providing either doing shopping or cleaning houses for, those things are provided under home care agency if that person is recommended by the healthcare professional who says, okay, this is the condition of the patient and this is why they need these services. Maybe it may require washing or cleaning or cooking for those people. And that if that happens, then we know that there are some therapeutic services being provided, maybe in terms of providing the medications or other services that require some skill. But when we deal with home care agencies that provide non-skilled, you don't like that word, but non-skilled services, they just they go in maybe once a week and cleaning the house for them, going shopping for them, or providing chore services, but there is no clinical need. We need to discuss that, how we can deal with that. But for us as a health department, we always depend on the overarching issue is healthcare service. And then those chore services are to support that.
As you heard in the earlier testimony, some individuals really appreciate them more than they do the skilled care, in terms of medication or taking the blood. That's needed too. But just to help someone get out of bed, to navigate them around their home, that's really important.
I understand.
And it could contribute to the overall health, so it definitely is needed.
I agree with you.
To prevent someone from falling down the stairs or from falling out of bed, or even a bed sore, maybe, so it's needed.
So that need would be established by clinically, and clinically there has been established, for example, there is an issue of a person who might be a fall risk, or somebody might have a bed sore, or somebody would have medication help, somebody needs medication. So that person should be supervised by a nurse, by some professional staff that will make sure that any clinical services, even providing their medication, should be done by someone who's knowledgeable. Because we have had issues where a doctor might say that give this patient one pill every hour. So we give them five pills, and I'll come back five hours later. So those could be a very dangerous thing that for us to make sure that doesn't happen. We have started licensing home health aides. They are going to be required to have some basic understanding of what are the services that they're providing, how to care for that patient, as well as to make sure that they are crime-free and they are ethical.
Well, I guess if that's going to be the case, then the rates, and that would be another division, healthcare finance, to look at that.
That's right.
But if they're going to have to raise the bar for their licensure, then we're going to have to look at, the reimbursement rates that we're giving them too. But that's a discussion in another committee, but I just wanted to put that on record too, that this will now lead to maybe some additional things that we
So
need
we're
to
finding
look
more
at.
and more people are now being cared for at home. There are some agencies who might have over 800 people that they care for, and then we need to make sure the administrator understands the responsibility and understands the magnitude of the care that these people need, and then we need to make sure that we hold somebody responsible when something goes wrong. And this is what we are seeking and looking for.
Well, thank you. Thank you all for your testimony, and Dr. Waldo, you're going to remain.
Yes, thank
for
you.
the other. We have now the Board of Veterinary Medicine, and is Dr. Del Ventos is coming up here. Is Dr. Garnier here?
She supposedly is en route.
Okay. And Lisa LaFontaine? It's just going to be you.
No, she's not, and we have audiology.
Well, it was a pleasure. I just want to announce that.
Audiology and speech language pathology.
Oh, come on up. I just wanted to announce that I didn't think about veterinary services at the circus, and I actually was able to go on a personal tour with the animals there, and it didn't dawn on me, so thank you, doctor. It was like, oh, wow, you guys are working out here, too.
Oh, this week alone, we had a panda that got away from the zoo.
Right, the number.
And we all found that, and then we also had that bear.
Wow.
So it was been an happy,
in
and
action.
we've been doing a very good job in terms of going after that.
I met my mascot, I met the tiger in person.
That's right.
And the elephants, which we're not going to go into that discussion too much. But let's say that they are very, their digestive systems are very good. But thank you, and I have a copy of your testimony.
Perfect. So Dr. Garnier has arrived.
Oh, welcome. Good afternoon.
Hi, how are you?
And I have your testimony, so once you get settled in, you may proceed.
Thank you. Okay. Good morning, Chairperson Alexander and members of the Committee on Health. I'm pleased to be here on behalf of the Board of Veterinary Examiners. I'm Dr. Julie Garnier, Board of Veterinary Examiners Chair. The practice of veterinary medicine in the district is small, but it's a very critical and growing field. Over the years, pets have played a larger and larger role in the lives of the district residents. In fact, today many families consider pets to be their children. The change in role of animals in the lives of people mean that we're living in closer proximity to animals, making the role of veterinarians critical, not only to the health of animals, but also to health and safety of people who may be exposed to pets, and possibly to the diseases that they carry at home or as they encounter animals on district streets or at district parks. Since the board became part of the Department of Health, we've been working diligently to rewrite the Veterinary Practice Act and accompanying regulations. Veterinary laws have not been updated since the 1980s. The practice of veterinary medicine is regulated alongside interior designers and funeral directors, rather than as a health profession. As a result, the current regulatory framework does not adequately reflect current standards in veterinary medicine, nor does it provide the board with the necessary tools to ensure that animals are protected to the standards that DC residents should rightfully expect. The new Veterinary Practice Act is pending as part of the Omnibus Health Regulation Amendment Bill and will bring veterinarians under the Health Occupations Revision Act. In addition to updating the regulatory climate for veterinarians, the bill will also authorize the board to regulate veterinary technicians, euthanasia technicians, and to ensure that animals are provided with consistent professional care by all types of veterinary professionals. We look forward to the passing of this bill so that we can begin taking the next steps towards writing accompanying regulations for veterinarians and creating registration processes for veterinary technicians, euthanasia technicians, and veterinarians volunteering for not-for-profit animal organizations. On behalf of the board, I'd like to thank you for your support, and we're pleased to answer any questions that you may have.
Thank you for your testimony. Before, you mentioned funeral directors. I'm wondering why mortuary, the Board of Morticians is under DCRA and not health. And I was just wondering, while we're in this bill, should that be moved to the health's purview. I know those persons are not breathing anymore, but
So that it's not a health issue.
but it's mortuary science.
Yes, we could talk about it, but what happened was in 1998 when they created the Department of Health, the health professional boards were transferred from DCRA. DCRA regulated all aspects of licensure because it was considered as a business license. But when the Board of Veterinary Board was not transferred to us, so they are not part of the HORA. So what we'll take is amending the HORA if your desire is to include the funeral directors.
I mean, no,
But
the
they do work
funeral
with us very
directors,
closely.
I can understand why they're under DCRA. I mean, that's a business, but mortuary science, I thought should be on this end of the
But
spectrum.
we only license funeral directors. I don't know if we license mortuary. I don't know if they do either that. But I
The
know
Board of Morticians.
there is okay. We'll look into that.
I'm going to bring them over here. I think
Okay.
that's where they belong. I mean, what would your recommendation be if anyone had a recommendation? I don't know if any of you have any expertise in that.
So,
but- but I
I've
just
not looked at
wondered-
it, so we need to look at it internally and give you our recommendation.
Okay, because I'm just wondering why that wouldn't be a health profession. I know that a lot of the function that they do, is health, related. So just curious on that. I digress for a minute. Dr. Nicolette, welcome. And I'm sorry, please forgive me, I didn't have you on the witness list.
Not a problem.
But I have your
I'm actually
testimony.
not a doctor, although I do have a master's in speech-language pathology.
Okay, masters, okay. When you get your
I'm
PhD.
misrepresenting myself, yeah. Good afternoon, Councilmember Alexander and staff. I am Gabrielle Nicolay. I'm a licensed speech-language pathologist and board chair for audiology and speech-language pathology. I'm here on behalf of the board. It's my purpose today to highlight some of the sections of the pending legislation as regards the practice of audiology and speech-language pathology. The primary change in the pending legislation creates a registration for audiology assistants and speech-language pathology assistants. Audiology assistants and speech-language pathology assistants are trained paraprofessionals who are qualified to perform a list of approved tasks as delegated and overseen by a licensed speech pathologist or audiologist. These tasks might include, but are not limited to, performing screenings, performing therapy, although not planning therapy, data collection, and file review. The use of assistants allows a speech-language pathologist or audiologist to focus more on professional-level clinical services, such as evaluations and planning treatment, which require clinical judgment, rather than daily operational activities. The second change creates a registration for clinical fellows in speech-language pathology. Clinical fellows are speech pathologists who are in their first year of work experience after having finished their master's or doctoral degree. They are qualified to perform any and all tasks outlined in the scope of practice for speech-language pathology with mentoring and supervision from a licensed supervisor. The pending legislation also removes the licensure exception for school-based audiologists and speech-language pathologists as per our discussions among parties at DCPS, OSCE, and the board. If the legislation is enacted, school-based audiologists and speech-language pathologists would be licensed by the Board of Health. Before finishing my testimony, I'd like the committee to know that there are some technical changes to the language of the bill that should be made. The changes would provide clarity for implementation of the new provisions, and I'm sure that the Board of Health staff would be happy to work with council staff to review potential changes. And I think you already have a letter to that effect. I'm happy to answer any questions. Thank you for your attention.
Thank you. So aside from the technical changes, there are no key proponents that need to be changed?
There are not.
Awesome. And what about for the veterinary board or for the veterinary portion? Are there any key proponents that need to be changed in the bill or that you feel are missing?
There's nothing that's key that needs to be changed. It's come to our attention that we need to write in one bit of language to make the animal shelters exempt from the description of veterinary technician, and we will take care of that in the next part of this in the open session, or I'm sorry, in the comment section for the bill.
One thing that we noticed for the definition was not included for the veterinary euthanasia technician. Should there be a definition included for that? And I guess if you could provide us with that information. What qualifies a person to be certified in that area? The euthanasia technician.
So a euthanasia technician is a special category where there are individuals that are trained specifically to handle the controlled substances that are necessary to perform euthanasia, and those individuals are typically employed by groups such as humane societies or wildlife groups where there is not necessarily a veterinarian on staff at all times.
Pardon us by that. By incorporating the practice of veterinary medicine as a health profession, will this allow for a superior standard of care to be created like in the other health professions?
Yes, they will be included into ORA, so they will be under the Health Occupational Revision Act. So all laws and regulations, which includes Chapter 40, 41, and all of the administrative laws will be they will be part of that. So it will strengthen their ability to do a lot of things that the health professions do.
So just to be clear on the fitness trainer.
Yes.
So will we be looking down the line for licensure for them eventually, or it'll just be certification?
Right now, the certification is as it's stated, certification is by an independent organization certifies them, and we register them. So the condition for registration will be certification. So once the profession matures and there is a need for us to explore a possibility of licensing them, we will be revisiting that.
And we had the conversation with the dentist with anesthesia. I know medical doctors, aside from what they do, they're separate anesthesiologists. What about in veterinary medicine? Are you able to do that as well, to administer?
Correct, we do it all.
Anesthesia. So why don't medical doctors do that as well?
They do. There is anesthesiology assistants that are licensed.
So there's
support anesthesiologists.
So medical doctors as well. I mean, I know
there are people who are specifically trained to be anesthesiologists.
Right.
And then we do also have anesthesiology assistants that support the anesthesiologist in a surgical theater.
Okay, I get
So
you.
they are separately trained and they have separate requirements, and they do have an advisory committee. They are regulated under the Board of Medicine.
But you see my confusion. Every other profession, veterinarians and dentists, they will administer to their patients.
But they do have, now they are also...
But surgeons often, they don't, an anesthesiologist comes in before the surgeon comes in. Surgeons don't do that.
Exactly. No, yeah, they are separately trained. And anesthesiology is a separate
So dentists and so veterinarians, you have had separate training in that. So a lot of doctors just opt out of doing that?
But it's not a separate certification. We're trained in anesthesia, we're trained in dentistry, even though we're not veterinary dentists, although there are veterinary dentists that are specially trained. But
we do have specialty boards, and there is a specialty board for veterinary anesthesia. There's a specialty.
But that is a part of your overall training. You have to have that.
Right.
So the medical doctor is first to become a doctor, and then maybe you want to be a surgeon, anesthesiologist, or internal medicine. There are different specialties. So there are people who go into anesthesiology, and they are the ones who control all of the aspect of anesthesia.
Right, but for a veterinarian, they don't have to say, well, your pet needs surgery, and we're going to call the anesthesiologist to come in?
I think it also depends on the scope of the practice. So some of the larger practices where they do a significant amount of surgery, they will have a person who is designated specifically to run anesthesia while surgery is taking place. In some of the standard smaller practices, the veterinarian, in addition to providing the surgery service, will also monitor the anesthesia with a technician.
Thank you. Well, thank you all for your testimony. Speech pathologist, you don't need to use anesthesia, do you?
I hope not.
But that concludes today's hearing. I'm sorry, one moment. Oh, I'm sorry. That was a very important question, because this has come up with the Board of Medicine with regards to the revocation of license.
Yes.
Are all the boards going to be able to do that in the event of any criminal activity? Are any of the other boards looking to have the power to revoke license?
Summer suspension. We're talking about summer suspension, right? Yes, that's what we would, if there are egregious violation, the board should reserve the right to summarily suspend the license until, further investigation is done. So we'll bring that recommendation to you.
Okay, because I know the Board of Medicine,
Yes.
I'm working on something with them, and is that something we need to look at across
Yes,
the board?
if we're going to go to that direction, I think we need to amend the HORA so that all of the boards have the ability to summarily suspend people their license, because they are really, at the end of the day, who license these people, and they should have the right to take it back if they feel that he's not or she's not meeting the standard that they expect.
Thank you. Thank you all for your testimony.
Thank you.
Mr. Syndrome has come in the room, and I have no further questions for you. Mr. Syndrome, the executive witnesses have already testified, but I will allow you 3 minutes for your public testimony. Would you be cooperative with that, Mr. Syndrome?
Why would I not have, Chair?
Well, come right on up. 3 minutes for your testimony. Good afternoon.
Good afternoon, Madam Chair. Always with the sound of my voice. Michael Syndrome, disabled veteran, served our country more than most. I have to, make you aware, Madam Chair, you and I have warmed up to each other as of late, but your staffers have not. And in attempting to sign up for this hearing, all right, they made it very difficult. This young man here I've interacted with, he seems very professional. And when we were having tender moments of bonding, Lena Smith, all right, I guess she's the committee clerk now, calls very rudely to disrupt my name placed on the list, come to my office. Couldn't hear what was being said, but I could have the chilling effect that as soon as I
Syndrome,
departed...
you were on the witness
All right.
list. You may proceed with your testimony.
I'm telling you, it was not easy, and this ought not be. Coming down here, is on our dime, if I may finish, on our dime, on our time. I know you cut me off in that, but I want to say what I have to say, and let me say it, please. Okay, I'm not in a Jeffrey Thompson financial line, which the paper has referred to as you, all right? And you and I have locked horns about Pepco. Remember Betty Noel? Every time I open up my Pepco bill, the outrageous amount, okay, it's not funny. Okay, I don't have a part-time gig for $125,000 a year, prime realty at the Granite Palace with full-time staffers. We don't. And the culture of corruption is alive and well. This is not good. The bottom line is, Madam Chair, I'm here to take care of business. So help me, help you, help us. Yesterday, when I brought this to the attention of your chief of staff, Ed Fisher, he starts yelling and ranting and raving. Now, God forbid, if I should do that, call security, I'll be buried beneath the courthouse. And we wouldn't even be talking right now. I'd be in a basis of carrot soup. Enough already, all right? And young man can confirm and verify all that I'm saying. Enough. I did, and I left the Examiner. Front page. With our friend, your friend, Obama. Train wreck. Why Obamacare could go off the rails, and in fact it is. Would you like to look at a copy of it? I can pass it up to you. I have one here, both of them actually. This is hurting our small business members. Yeah, Coach? But the point is that this is hurting us, and it's not a panacea, all right? And as has been said, we have a black president. What is he doing for us? I can't fathom that he's helping us. He's hurting us in this instance. I like liberty of contract, the supreme law of the land, where it says I have a choice. But when I'm strong-armed to do something that I would not ordinarily do, that's not a choice. In fact, when we talk about this Affordable Care Act, right, I'm currently under care with Dr. Donna Reed, a prosthodontist in Alexandria.
Mr. Syndrome, you've run out of time.
Guess what? She cut me off, and she says, why? Because Medicaid doesn't pay her. So who am I going to be treated by? Okay? Last but not least, how about appearing by telephone? The council doesn't have a reasonable accommodation by phone. Now, you all make the laws. Come on now. Every other agency, branch of government provides for a reasonable accommodation by phone. Why not appearance here at the council?
Thank you, Mr. Syndrome. This concludes today's hearing on Bill 2153, the Omnibus Health Regulation Amendment Act of 2013. I want to thank all the witnesses who came today to testify. Copies of your written statements may be submitted to Ms. Raina Smith, Committee Director, Room 115 of the John A. Wilson Building. The time is approximately 1:15 p.m. and we are adjourned. Thank you.